So I'm very excited to share, and you will have to wait till the end because today I think we are going to introduce something that has been really interesting and a lot of debate. But let me walk you through the way we think about this. We have seen it, and I have to say, stop it to guys of Pentacam of giving us more and more valuable information, because each time we have to think on more things. But information is flooding from everywhere. And the truth is that we are still the same human beings with the same time and the same processing our mind. And we need to take into account much more variables. So I'm 100% convinced of what Pooja was saying about AI and everything. It will be just a necessity, a solution for us, because we truly need to understand what are we going to do in each patient, when, how, settle the correct expectation because of that clinical and the follow-up. And at the end, we are cataract and refractive surgeons and cornea, whatever. We will need to address all the specialties in each topic to be able to deliver the best solution. So the biggest challenge that I think we are facing is the quality of data, because everything will rely on the quality. And let me share with you a couple of things. When we compare different IOLs, that is at the end what I'm going to share a little bit, is most of the time we rely on a specific publication with very controlled prospective data done in a low end with some parameters, with patient satisfaction. But the truth is that these are subjective numbers, subjective data. And we need to start thinking on how can we jump a little bit and improve this to have something really strong. So for example, I put you a very clean example. There is Roberto, my father, and this is the same standardized chart with same illumination at different times, because there is a window and you have light getting in, and that's the performance of different patients with different lighting conditions in one room. You have a big variability of things. So it will be more and more important to have really reliable data, the material and everything. And the other important thing that is what we most of the times evaluate the patient-reported outcomes is, it's not the same to have a controlled study and have the feedback of a patient if they haven't paid, if they have paid, if they have hard cataracts, if they don't have anything. This changes completely. We need to understand what were the expectations of that patient, what was the standardization of the expectation. I'm just trying to make you understand how complex it is to be able to compare apples with apples. It's very difficult. And this is what we have been working a lot. We have a process in my clinic and in a big project called Revive, that I'm going to share very quickly something about that we are taking care of all these details to be able truly to understand the data and compare one thing with another one. So this is, for example, our 3-method strategy to align patient expectations depending on each procedure. I send them a video explaining each specific IOL. We send them an explanation. They sign that they understand the 3-4 most important points of each IOL, full range IOL, EDOF IOL, monofocal plus. So we put them in the same alignment of understanding. So why do I like a lot the Pentacam Wave? Because it's my platform to get, in a very fast, efficient, and effective way, and reliable way, a lot of objective information that, of course, I'm going to relate with the satisfaction and everything. But I need something to provide. Of course, dry eye testing is an add that you need with the keratograph, but in general, you have all this information. And every single patient in my clinic, 100%, as soon as they get in, they get a full workflow of the Pentacam Wave. It's extremely fast. How many of you have Pentacam Wave here? You can raise your hand. Okay, there's a lot that will think about it, hopefully. But this is what you do. It's just a workflow. There I'm hitting very quickly 5 shots. You get the aberrometry, which is absolutely critical, the pupil size, retroillumination, you get action length. And this is, and I'm not a technician, and I'm doing this very easily. You can see the time, this is real time. And then at the end, you get the tomography with all the great Pentacam, Bellini Ambrosio, and all the spectacular things that we all know. But this is how fast it is. So this, let me show you the interesting thing. So all this information, we are processing it, it's automatically absorbed by Revi. And the beauty of this is that we start having all this information in our business intelligence. So we have all these objective parameters that are automatically absorbed, and we can cross-match with the satisfaction of each patient, with the pre-op assessment and everything. So we are putting everything together. So let me put you some examples on why this is going to be so critical for our future. For example, you have this patient, I shared it 2 days ago. -5, both eyes, 0.5 astigmatism, normal cornea, good pachymetry, breakup time 10 seconds. How many of you, with this information, would think about in a femto-LASIK procedure? No one? No one is doing femto-LASIK here? Why? What is the problem? Okay, but it's a nice topography. Okay, you're all cornea specialists here. It's a nice topography. How many of you would do a smile procedure? How many of you would do nothing? No. How many of you would do an ICL? Okay, so the patient was extremely happy. This is a post-op result. You see, everything looks good from the cornea, from internal to and everything. However, the patient is not happy with the surgery. He's not happy at all. Normal topography. Where do I fail? Look, daytime, 3.26 millimeters, very nice aberrometry, everything looks great. Nighttime, terrible vision, very unhappy patient. The guy has a 7 millimeter pupil and has 1 micron of aberration during nighttime. So now I have to give him some drops with diluted pilocarpine to decrease a little the pupil to improve his quality of vision. So these are the kind of things that we are going to immediately trigger a decision if we have everything integrated with something guiding our results. Very quickly, I shared this yesterday. So there are some options, for example, that this would have been much better, for example, with a low myopic ICL, because the effective optical zone is bigger because of the retroiridial position, and it's translated in a bigger optical zone. This is a prospective study that we are doing, comparing three different procedures, and you can see that the deviation, the standard deviation, and the range of microns of induced aberrations is much lower with ICL, at least in this small group of patients. So let me go quickly. I don't want to take my friends' time. We are studying all these aberrations, and we are putting everything together to have a predictive analysis. Very quickly, another case. This is a woman that has an old procedure in another center of LASIK. You can see a decenter ablation. And that's the cornea aberration. You see that the cornea is very aggressively aberrated. She already has a cataract that you can see in the internal aberrations, and you can see in retroillumination, and her quality of vision is not bad, it's not good. So what do I do here? If I do a toric, is she going to improve? Who says that you would do a toric if you do a standard cataract? So it won't be a solution. If you put a monofocal, you see that the problem is in the cornea. She has double vision. So what I finish doing is I do a small aperture IOL, and with this, she completely, and don't have time, but she's extremely happy. She finished 0.75 with really high improvement of quality of vision. So the point is, I can keep going on all day. I have many cases, but let me go. Okay, sorry for this. It was a longer than expected. So understanding all the cutoff, like Joaquin Fernandez has taught us, putting all this information in a reliable way with satisfaction, with the performance, with everything, we can prospectively predict who has more chances to be better after each procedure. And this is what we are working a lot. Joaquin has taught us that, for example, with the PNS that you have it here in Pentacam, if you are going to put a multifocal, you have to have a PNS higher than 1, which means that you already have to lose some clarity, you need some opacification. Same with the OSI, the Objective Scatter Index, which is very important. But the most important thing that we have learned, and I have to congratulate Sven from Pentacam team, from OCULUS team, is we are collecting a lot of data regarding high order aberrations and chord mu. Chord mu has always been something gray. There is heterogeneous evidence in the market. It's inconsistent. We never finish understanding if it's really important or not important. There are some big data suggesting that there's no importance at all. But however, now that we are working in a very systematic and controlled way, for the first time, we collected 1,075 eyes from 3 clinics, and we are seeing 3.3 more chances in odds ratio to have more dysphotopsias if the core move is nasal. And if you remember, we always have a temporal shift of the core move in most of the patients. However, if we have negative, if we go to the other side, to the temporal side, we have 3.3. This is extremely important. This is one of the important things that we are finding. The more data we collect, the more things like this we are going to find, and hopefully we are going to put this together in an algorithm with predictive satisfaction in order to reassure better and better results. This is, of course, something that is prospectively addressed. We are going to keep adding more and more information. Just to finish on time, everyone is convinced that AI is the solution for everything. Everyone knows this. However, AI, if you don't have extremely reliable data sets, very reliable in terms of all the conditions that you have built in order to predict the future, it's not going to be reliable. And that's what we are doing here with this great device. Thank you for your attention.